in community of Langley as a community pediatrician, as well as some specialty in adolescent medicine in her private practice. And Tara has also worked with the South Fraser Eating Disorder Program since 2003 and with the Provincial Eating Disorders Program at BCCH since 2007. She, in addition, in the community and at BCCH, is involved in undergrad and postgraduate teaching and community education. In addition to all the letters that Tara has after her name, you know, the FRCPC that we all have, she also has MOT, mother of 3. Tara is going to talk to us today about ARFID, New Home for an Old Problem. I don't know how to use this thing. This is not signal.
She would have used her neck.
I think it was loaded in there, wasn't it?
She wanted to use her. Thank you.
Okay, good morning. It's been a really good morning so far. It really has. So today I'm going to talk about avoidant restrictive food intake disorder, and I'm going to wear the hat of an adolescent medicine specialized person and a community pediatrician care provider. So maybe a different angle from what you've heard before. I have nothing to disclose. What I want to talk about is familiarizing you guys with the DSM-5 criteria for ARFID, because as you recall, it is a new diagnosis. I don't know how familiar people are feeling with it. I'm actually curious, maybe just with a show of hands, how people are feeling about this diagnosis, because you've heard of it, but how comfortable are people feeling using the DSM-5 criteria and applying the diagnosis? How will we gauge that? People that are feeling super comfortable, can you put up your hand? People or people who are feeling not that comfortable, help me understand. Okay, good, okay. Okay, now I can relax. So I have something useful to say then. We'll go over the epidemiology. We'll talk about the CPSP study that's ongoing right now on this topic. You guys are getting those, you know that they're studying this right now, right? You guys have all seen those questionnaires. And then we'll talk a little bit about the treatment, okay? So, it's working. So I thought I'd start with cases. I've got 4 cases to represent sort of 3 subtypes that is ARFID. So the first one, I'll just tell you a story. This little boy, we'll call him the young and the picky. He is, or he was when I first met him, a 5-year-old boy, and really ridiculously picky with food. He had like the tiniest list. You guys have all seen this kid, right? The one with, you know, the list that got smaller and smaller and smaller, and then he has 5 things that he can eat, and they're all white. He has biochemical evidence of poor nutrition. He has a low vitamin D level. He has a low albumin level, and he's constipated from his crummy diet. And he's maintained in terms of his growth curve, which is great. He has 2 Pediasures a day to accomplish this, unfortunately. And he is also really, his neurologic profile is interesting. He's really smart. He's really good at math. He's a little obsessed with numbers. He has these little things with football helmets. He has all these little football helmets, and he likes to organize them, and he actually does these intricate charts with football statistics about all of the different teams in the NFL, and it's quite elaborate and accurate. And he's got some behavior issues. He struggles with transitions. He tantrums. He's noise sensitive, and his poor mom is worn out. There's this whole food entity issue, and then there's this whole other entity that she didn't come in to talk to me about, but it's sort of there in the background. So she's starting to wonder if maybe he should see Dr. Fitzgerald. Actually, he just came back from Sunny Hill quite recently. I got the report, and they said, no, you know what? He's not actually on the spectrum. He's ADHD and gifted. So it's just... So it's interesting, and maybe I'll ask you a question later, because that ADHD plus comorbidity versus autism piece, I find that interesting, but that's for another conversation. Second case, so that's a face of ARFID. That's a face of ARFID. Another face would be, we'll call her the supersensitive preteen. So this is a 12-year-old girl with a known learning disability, very sensitive, getting worse as she gets older. So light bothers her, sounds bother her, feel of stuff on her skin bothers her, smells bother her, taste of things are a big issue, texture of things. She's one of the most anxious people I've met. Having a conversation with her in the office is really awkward. She comes in and she'll be like, you moved that picture. That picture wasn't there last time. So she's very controlling, very hypervigilant, very sweet. History of severe behavioral outbursts, strong mental health family history, lots of chaos in this family, real extreme. As far as the eating goes, her mainstay for many years, her entree is chocolate chip cookie, cream cheese sandwich. That is the entree. That's it. She's maintaining her growth curve, amazingly enough, except when life gets really stressful, which this year has been rough. There's custody stuff, and it's been rough, and I've watched her cross percentiles downward in the midst of all of this. And then we get things back on par, and then the stress comes in and she tanks again. She has no body image concerns at all. Of course, I asked, right? And she's really embarrassed about her eating issues, and she really would like them to be better, but really has all of these barriers to them being better. That's a face of ARFID. Here's another one. This is another prototype. Remember, there are 3 prototypes. Big boys with small appetites. And I'm thinking of 2 big boys. They were actually not that big, though. They were old boys. I should have called them old boys, because they were both really, really underweight, actually. So the common theme in both of them, they were like late teenage boys with long histories of ADHD, followed by psychiatry, treated with medications on and off, comorbid anxiety, always picky eaters, escalating depressive symptoms over time, withdrawal, hypersomnia that can go with the depression. One of them was in school for a couple of years. He was a video game addict, so he was in the rec room playing video games, sleeping, and not eating. And his poor mom, you can imagine, trying to approach this over all of these years and, pushing really hard, and then, backing off, and different professionals say this, do this, don't do this, you're pushing too hard, you're backing off too much, do this. And she had heroic attempts at trying to get this guy to, meet nutritional sufficiency, and she was at her wit's end. And I think the referral might have come from a psychiatrist for me, who noticed, having followed the child for many years, and he's now 16 or 17, that gosh, he really looks really thin. And he was like centimeters below the third percentile on the growth curve. And his Z score, I just thought I would mention for because the lab radiographic thing was minus 1.8, and you'll know minus 2.0 is below that is considered abnormal, but you don't really want to be right beside abnormal. It's still like 1.8 is still a low DEXA score. So his bones are suffering. A face of ARFID. And the last one we'll call her the mind-body connection girl. And man, there are many, many kids I can think of like this just in my last 3 or 4 days, but we'll talk about this one. So she was ARFID and somatic symptom disorder were her diagnoses. 16 years old. She was previously athletic. She had some background history of anxiety, or at least an anxious temperament. I don't think she was ever diagnosed with anxiety. She develops chronic abdominal pain and nausea, and it leads to a massive decline in her life. She can't eat, so she loses weight, and it keeps going. And even I met her and I set the stage right away for, we're working up the medical side of this, but let's also introduce the concept of somatic symptom possibility. And even with that, I walked down the path with them as her weight continued to tank and tank. 80 pounds this girl lost in the end. Functional decline to the extreme. She would come into my office carrying a vomit bowl, and all of the other kids in the waiting room were like, freaked out by this seemingly infectious kid. But she was mostly spitting. She was less vomiting and more spitting. And she was really cachectic. Again, zero body image concerns. Right? And she became essentially bedridden. She started to develop musculoskeletal kind of complaints, and it was back pain. She started walking with a cane, so it was the cane and the vomit bowl in the waiting room. This is a previously functional, athletic kid. That's how she presented. So another face of ARFID. So what are the common themes? Something is getting in the way of eating. And it's not body image, because you're going to ask that. And there are big consequences. They're significant, whether it's physically or functionally, there are big consequences. So, I'll let you read. I really like the sock thing. I like the sock. Well, can you read it? Can you actually read the sign? It's, this is so hard. It says, oh gosh. Yeah, the top says like welcome new participants or something. Socks without partners. The last thing I remember was being thrown into the dryer. And then the other one I think you can read fine. So the point of this was like, there was a lost population here. These kids that I'm describing, they had no place in the DSM-4. There was no place for them. And yet they were around, right? Because did you guys have patients like this? Come on, put up your hands if you've ever seen any of the, okay, right? So good. We know that these patients have always been around. They're not new, but they didn't actually really have a title. So the DSM-5 working group, the eating disorders working group, was tasked with improving the clinical utility of the diagnostic categories for eating disorders based on what they used to be in the DSM-4. They also were tasked with reducing the frequency of EDNOS diagnoses. You remember the eating disorder not otherwise specified diagnosis, which honestly, of all comers who were diagnosed with eating disorders, the majority ended up getting EDNOS diagnoses because the criteria for anorexia and bulimia were actually quite tight, quite restrictive. So to actually squeak into those diagnoses, it had to be very, very, very specific. So that wasn't super useful. And the other thing about the DSM-5 is that they wanted it to be a more developmental lifespan approach. Do you guys sort of know that general concept? They want it to be not just like this affects this age group, this affects this age group, but more developmental and lifespan approach. So with all of that in mind, they decided that they would replace and expand a category, which was the feeding disorder of infancy or early childhood, which applied to kids that were under the age of 6 years. And the two things that were in that were pica and rumination disorder. So it had nothing to do with these ARFID kids, but they used that category and they added to it, and they said, let's let's make up a title called ARFID and put it in that instead of that category. And this would capture who? It would capture patients who can't eat, who are having consequences, and it's not body image. It'll capture them. So their new baby, DSM-5's new baby. 2013 is when that happened, right? And here are the criteria. So it's an eating disturbance with avoidance, and it's going to be based on, remember these three things. Concern with adversive consequences if you eat, apparent lack of interest for eating, or avoidance due to the sensory aspects of the food in some way. And the result, persistent failure to meet appropriate nutritional or energy needs, causing one or more of either significant weight loss or failure to thrive, which can, of course, then lead to pubertal delay, significant nutritional deficiency that warrants clinical attention, dependence on enteral supplements or tube feeds, or impaired psychosocial functioning related to the nutritional aspects of what's going on. Okay, and that's an important one because sometimes the first three won't be there, but you look at the function and the function is really affected, and that counts. It's nothing to do with being a specific religion and fasting or not having enough food due to socioeconomic challenges. It's not due to body image, and it's supposed to be not better explained by an alternative diagnosis, either medically or psychiatrically. But that being said, you can have two things going on. You can. So you can have the depressed patient who is not hungry and loses weight. But if you lose way too much weight and it's affecting you physically and functionally, and it's enough of a big deal that it warrants separate clinical attention, you get a diagnosis of depression and ARFID. Okay, so that's really important because as we learned about this, tried to understand it, it was confusing, could you do both? Well, yes, that was the point. If it's a big issue, the nutritional piece, they get a diagnosis of ARFID. You can have Crohn's disease and ARFID. That's the example. So I decided to make up a metaphor, because metaphors are big these days. And my metaphor was going to be painting and art and colors. And then when I was kind of practicing to do this talk, I kind of realized that there is 8% of males and 0.5% of females. I looked up the stats last night, might be colorblind. And so then I thought that was a bad idea that I'm using colors. But can you see them? Because what I ended up doing to compensate in case there were colorblind people in the audience was I also did the little squares, the little icons with something else to represent the three categories. So it's done in two different ways. But going with the theme of art, the three primary colors of ARFID, the three things the categories I want you to learn are red, blue, and yellow. And red represents fear of aversive consequences, blue, lack of interest, and yellow, sensory sensitivity. So red, at the bottom, you see avoidance with the stop sign. Blue, you see disengagement or oblivion with being unplugged. And yellow, you see resistance with a caution sign. So those are the three areas. So these are thought to be the maintaining mechanisms for the disordered eating, right? So examples of the red category would be somatoform symptoms like abdominal pain and nausea, or maybe a fear that you're going to have to go to the bathroom and defecate. So I had that last week, somebody who didn't want to eat because they didn't like public bathrooms and they didn't want to, eat for that reason. A fear of choking, a fear of vomiting, a fear of an allergic reaction to food, any of those things. The lack of interest blue category would be examples like depression and oversleeping. You may have the ADHD phenotype person who really just, you guys have maybe noticed this, that many of your ADHD kids are not sometimes that interested in food. They're kind of busy and, not interested in slowing down to eat, and maybe just don't have just the real drive to eat that, other foodie type people might have. And then, of course, the stimulants and the appetite suppression can sort of compound that. And definitely there have been case reports of ARFID, associated with stimulant use for ADHD. Then the third group, the sensory people, of course, it would bring to mind autism spectrum disorder. So that may be a piece that exists in that group in some of them, or sensory processing, sensory integration type disorders, maybe another piece. So people have hypothesized, what is underlying this? And this is where, when I'm talking to families, they're tearing their hair out trying to understand, why is this such an issue for my kid, right? So these are some of the hypotheses for why neurobiologically. So the fear group, maybe they are the folks that have an elevated, fear response and an elevated response to anxiety and loss. And there's a term, and I didn't really know much about what it meant until I started looking it up. But in psychiatry, they use the term neuroticism, and that's actually what the definition of it is it's like an elevated response. It's like looking at the glass half empty. That's kind of what that captures. So. That may be a piece. In the lack of interest group, it's hypothesized that there may be an altered homeostasis in terms of, your reward circuitry, your midbrain, your amygdala. How is that working when you're eating? Because food, in theory, should set off a cascade of positive things happening in your midbrain. But for some people, that may be diminished. And they're currently in Boston, doing some neat studies with fMRI, and they're looking at this. They're comparing anorexics and kids with ARFID, and presenting them with food-related visual stimulation or actual food, and seeing what's lighting up and seeing the differences. And they're seeing big differences, like the anorexics, and the folks with anorexia who are using parts of their brain to suppress their desire to eat, and yet lighting up in the midbrain when food is presented, whereas the ARFID kids, not lighting up in the reward circuitry is quieter than the anorexic. So that's preliminary stuff. It's not published yet, but that's what they're finding. And that's what was presented recently at the International Congress of Eating Disorders. And then the sensory group, at last year's Society for Adolescent Health and Medicine conference, again, I think it was the Boston group did this presentation, and they said, okay, guys, I didn't have time to do this, but if I were to hand out some filter papers, and they were impregnated with some kind of a flavor, and I said, okay, everybody put this on your tongue, and then put up your hand and tell me what your experience is. There would be a group that would say, didn't really taste anything. And then there was a group that said, yeah, I tasted it. It was fine. It was whatever. And then there was the third group that was like, this is the most disgusting thing that has ever been in my mouth, right? And that's a small subset, but, that was the example of super tasters. So it's just the acknowledgement that people have different palates. We know this, but some people have really, really, really sensitive palates. And who, those of you in the room who've been pregnant and have experienced taste aversions during pregnancy would kind of, make that connection that maybe being one of these super tasters, like being permanently pregnant. Color mixing is common. So that is to say that when you're looking at those three big categories, and you're trying to figure out, why is this a problem for this child? Half of them, it might just be one category. Half of them, it's going to be two categories, and a small proportion, like 4%, may have all three. And it really informs how you're going to help people understanding what's actually driving the problem. So, you have to ask the question when you meet these kids, what's getting in the way? Are you afraid something bad's going to happen when, if you eat? And what is it? So, the first thing you of course have to differentiate from anorexia or other classic eating disorders. So you're going to do the body image questions, and there's a whole conversation we could have about how you do that in a 9-year-old in a sensitive, careful way that captures the information you want. But if you get a negative answer to the body image stuff and you don't think it's an early onset eating disorder or an eating disorder like anorexia, then you go on to, you worried that it might hurt. Some people worry that it might hurt or that they might feel full and they don't like the feeling of being full. Some people might worry they will have a panic attack. Some people might worry that they're going to get sick or throw up or choke or have an allergic reaction. Some people are just not hungry and they're busy and they're not interested. Does any of this fit for you? And you'll find that some kids just won't be able to articulate why. They'll just be like, I don't know, just doesn't look like something I want to try. Don't think I'm going to like it. I know I'm not going to like it. There's something green in it and I'm not going to like it. So, this is like a simple statement, but I think it's really true. Nutritional restriction, by and large, is a bad thing. It certainly maintains eating disorders because when you're restricting, it increases the negative emotions and predictions that people have about food. And once you're in that place, you continue to restrict. And as you restrict, your body changes and your gut slows down and your body doesn't process food in the same ways. And then you experience discomfort with eating, which reinforces the negative predictions about food that you had in the first place. So you continue to avoid, your anxiety goes up, you continue to avoid, and you go around in a vicious cycle. So it really, really is difficult once that cascade is set in motion. So we already established that everybody's seeing ARFID, right? We are all seeing these kids. So therefore, in a way, we really shouldn't be intimidated. We can embrace this and know that we're all seeing this. How many of you are feeling like comfortable? How do I say? Like, do you feel like you come up with comfortable plans? Like you feel like you're no. Yeah. So. I'm trying to be positive, and I think I should be positive. I do want to acknowledge that I think it's tricky because there are all these 3 big groups, right? And maybe it will help if for yourselves you break them down and go, okay, well, what's driving it? And at least then you can try and target specific things because it can be hard. But I will tell you the resolution of some of these cases, and it is optimistic. Like kids can improve. So there's stuff you can do. And I just wanted to point out this PEDS GI thing. So in the Boston area, there was a retrospective chart review done where they, with all the new referrals and all of these GI clinics in the Boston area, they applied the diagnostic criteria for ARFID to see how many ARFIDs were actually just in the new referrals for the GI clinics in that period of time. And they got 2.4%, possibly, and 1.5% definite diagnoses of ARFID just with new GI referrals. So the gastroenterologists are seeing them. The psychiatrists are definitely seeing them. So it's about recognizing them. Everybody's seeing them. And I have heard from, dietitians. I have heard from eating disorders teams. I have heard from occupational therapists. And a lot of people express some discomfort because they say, I don't know really how to service these patients the best. And I think it's about tailoring. I think it's really about tailoring to what's actually going on for the patient. So just briefly, epidemiology-wise, this was the eating disorders task force for DSM-5 that came up with this. So this, is the adolescent medicine presence that kind of developed this category. So in terms of some of the people that are studying it, then it's the tertiary care eating disorders programs that are actually doing the research and publishing and there's really limited data because this has only been going on for 4 years. But it's tertiary care information that we have in terms of the epidemiology. So Mark Norris, he's an adolescent medicine pediatrician. He was here for about a year, about 5 or 6 or 7 or 8 years ago in adolescent medicine here, and now he's in Ottawa. And he published some stats from prospective chart reviews, and he came up with about 14%, range 5 to 13% of patients coming through tertiary care eating disorder clinic will have a diagnosis of ARFID. And as far as community samples, we don't really know. Like, we don't really know. Hence the CPSP study, right? To elucidate all kinds of things, like, what is this entity? What does it look like? Who's seeing it? How are you treating it? What are the comorbidities? That's why they're doing the study. So, like, just last week, I think I got an email, you probably, maybe all saw it, talking about some preliminary data from this study. It's supposed to go just till this December, but I just picked a few points from what I read in the report so far. There's a 61% male, 39% female split, and that may strike you as different from anorexia, right? Because there's a pretty high proportion of males that have ARFID, and in anorexia, classically people think of it as a female disease. Now it's not exclusively, but definitely the numbers are going to be lower for males in anorexia than they appear to be in ARFID. The other thing is the comorbidities, because there are often going to be comorbid things going on. So 54% having anxiety, 17% having ADHD, 11% depression. So just some examples of common comorbidities. This is important. Average length of illness before diagnosis is long. 35 months is a pretty long time to be sitting with this, with malnutrition. So we need to be early birds in the diagnosis. So where and what for management, right? That's the magic question, I guess. Should they all come to the inpatient eating disorders unit at Children's Hospital? Is that the place for them? What about the secondary care eating disorders programs in the province? What about day treatment programs? So I think this is I was speaking to a colleague from another center, and I think the way I would talk about this is just, I think each patient needs to be, their case management needs to be case by case. And I think the factors that affect where they should receive their services, at least in talking about the eating disorders program question, depends in part on the program philosophy. So if you want to know the clear answer for here, it's not clear. It's because this is so new, it's evolving to figure out, who can we see and who can we service the best? It depends on the resources, right? So if you think about what inpatient eating disorders programming looks like here, it's pretty centered around teenagers, mostly girls, some boys, with body image issues. So the groups and such, that are part of it are developed around that. So resources and philosophy. Age, of course. What's the youngest age? Because we know that this is lifespan. Now, you can have ARFID when you're 3 months old. Does that child go to the eating disorders unit, right? Or if you're 4 years old, does that child go, like our first case, should he go to the eating disorders unit with the 18-year-old anorexic? So I don't have answers because it's not clear, but I think there are different factors that come into the decision making. People worry about being in the milieu with on the unit and the potential for being exposed to different things that you have not previously ever thought of. I think that's a question, and again, people would have different perspectives on whether that really is something you should worry about or shouldn't worry about. But then the things that are common, like starvation is starvation, right? Everybody agree with that? Like it matters. And starvation from a high BMI to a normal BMI is still starvation, and it's still bad. And so the physiological effects are the same. Starvation is always bad. And the one thing about intensive eating, like inpatient programs and intensive support programs for eating disorders, is they actually know how to refeed. That's what we do know how to do. Like, we can do that. And so that's important to acknowledge, because, I don't know a lot of other places that are supported to do that well. So adaption, this slide is supposed to be about adaption. I think what is fair to say is that eating disorders programs are going to need to adapt their programming to serve some subset of this population, and it still needs to, be clarified exactly which subset it's going to be. And you can read the slide. I don't know if it's too small, but this is like the one that's obscured is it's like a furnace in here. So these creatures are not happy with the desert after all. So very quickly, management role of the pediatrician. I say this whenever I talk to people if they ask me advice on patients. Your first question, whatever kind of eating disorder you're talking about, your first question always needs to be, do I need to admit this patient to wherever I can admit to? You're going to use the criteria for medical instability from anorexia because that's what we have. We don't have a criteria for ARFID, and really starvation is starvation. And you can look them up, on the internet, and I've given you a reference there. So the SAM is the Society for Adolescent Health and Medicine. Pay special attention to the criteria of being severely underweight, so less than 75% of suggested body weight, or just severely underweight, just saying it that way. Be attentive to whether the kid is just having acute food refusal, even if they have a normal BMI, but if they're going 1 or 2 or 3 or 4 days of just not eating, maybe that's a reason to bring them into the hospital. Failed outpatient management and arrested growth and development. These are things I just want to highlight as potentially reasons you might want to consider admitting while you then figure out all the other pieces that you're going to do. Clarifying the diagnosis, excluding the other potential diagnoses or comorbid diagnoses would be important, including flagging the psychiatric pieces and then getting help with that if you need further diagnostic clarification. Helping treat, follow at least the medical side of the ARFID issue, weights, vital signs, lab parameters, and then trying to figure out where to refer to if you need to tailor things further. And providing education and support to the family in the best way that you can with a difficult problem. You start with psychoeducation. You try and highlight which combination of the 3 groups are the maintaining mechanisms for your patient. And then you consider things like, and multidisciplinary seems probably like the way to go, because you're going to at least provide the medical piece, and then you might be reaching out to, maybe it's going to be a dietitian who could help you with a variety of different things. Maybe it's going to be an occupational therapist. That's hard, right? Find an occupational therapist with an interest and expertise in this. That's difficult, but not impossible. Maybe you're going to refer to the complex feeding and nutrition team at Children's Hospital. You may be considering involving somebody from mental health. So that could be psychology, that could be individual therapist, counselor, that could be your local child and youth mental health team, that could be your secondary level care eating disorder program in your community. Family-based therapy, which you guys have heard about before, is something that's been adapted and used to treat ARFID. That's one way. Another way is, obviously if there's anxiety, deal with the anxiety, use the CBT, use the graduated exposure kind of anxiety treatments. Similarly, treat the mood issues and the comorbidities. And support the family, and that may take family therapy to deal with something that can be pretty destabilizing when there's meal battles for everybody. You may involve psychiatry. So, are you talking next? Perfect. Soon. As soon as I stop talking, you're going to start talking.
30 seconds.
30 seconds. Okay. Yeah. So you may involve somebody who could clarify around somatic symptom disorder, somebody who could help you with the pharmacological management piece. And we could talk more about what, medications are sometimes used, SSRIs being some, atypical antipsychotics sometimes being used. But there's not a lot of treatment studies. I have 2 more slides, I think. I have 36 minutes. No? Over time? Yes? All right. So there's a really interesting trial out of Boston right now where they've come up with a manualized approach to these kids. It seems like amazing. It's super resourced, but they're just kind of gathering patients and trying to implement it. And it's called CBT ARFID. And it's in 4 stages, and stage 2 is the weight gain stage, and stage 3 is the addressing, maintaining mechanism stage, the 3 groups. And the idea is that you create a matrix or a hierarchy of foods that are a challenge, and then you work through slowly, and you do some work with exposure and some work with neutral reporting of, you know, what does the food smell like, taste like, feel like, what's the texture, et cetera. And then you work through like developed modules on the maintaining mechanisms. And then second to last slide is just looking again at the 3 categories. I thought these were some neat things that I hadn't heard of before. For the exposure therapy, interoceptive exposures, like, you know, trying to get used to being nauseated and full and bloated by doing particular things like spinning around in a chair or drinking or doing belly exercises, interesting ways of exposure. And then the CBT kind of approach to exposure therapy and the medications for anxiety. And for the people that aren't interested in eating, you know, they have to eat by the clock. It's like timed mechanical eating, treating the depression, and sometimes medications that help manage the mood might also help with the appetite. So some medications will actually stimulate appetite as a side effect, and sometimes that's a welcome side effect. And then the yellow folks, it's the gradual exposure. And the yellow folks are the ones where your occupational therapists are going to be useful. We don't have really much data on outcomes and prognosis. And if I were to follow up on the cases really quickly, the little guy, the young and the picky, he's still a work in progress. The super sensitive preteen, still a work in progress. She's on a wait list for the West Coast feeding and behavioral specialists who are occupational therapists who privately do this kind of work. The big boys with small appetites both came and got services through the eating disorder program here and put on, 40 pounds and are functioning much better. And the mind-body connection girl also had services here in the eating disorder program, having come in very cachectic, and got her function back, got her weight up, and is doing much better. So what we do know is that it's a work in progress. 39 minutes.
Thank you very much, Tara. That was excellent. And if anybody has questions, they can ask Tara at lunchtime.
Thank you.
Thank you. I'm pretty mean, aren't I?
You're pretty mean. I still love you.